We are now recording. Over to you.
Thank you. Thank you very much. Thank you everyone for joining. So my name is Uzma and I'm a GP in Dagenham. I look after a few care homes here in Barking and Dagenham, and I'm also work in Nelft, so I'm Deputy Chief Medical Officer. And a lot of my work is involved with physical health, so intermediate care beds and a lot of interactions with neighbourhoods, development in the community. So today's session, we've had a lot of requests to do a webinar or teaching session on delirium. So we're going to go through lots of aspects of delirium. And so we've got here today Dr. Hack here with us. He's a consultant geriatrician from Barking Havering Redbridge University Hospital, predominantly based at King George Hospital. And he does multidisciplinary team meetings in Redbridge. So any Redbridge care homes, the GPs, via the GP, patients are discussed with him. So just a few housekeeping rules. So we'd like to keep it as interactive as possible, and it's informal. So please do ask any questions you would like. You could raise your hand, and then Khalid will respond at a time when he can. So when you're not speaking, maybe you could go on mute, because then that will help with the flow of the whole of the presentation. You can also put your questions in the chat. So if you got anything, I'll keep an eye on the chat, and Khalid will also. So when Khalid comes to a natural end or pause, we will answer all the questions at the end. But if there's any burning questions, please put your hand up, and Khalid will let me know, like when, or Khalid will automatically directly talk to you and just answer any questions. So before we start, are there any questions anybody would like to ask? If not, then over to you, Khalid.
Yeah, thank you very much, Uzma. So I'm Khalid Haq. I'm one of the geriatricians at King George, and I mainly look after the beach frailty unit, which is acute frailty unit in the hospital. I also do some multidisciplinary team meetings for the care homes in Redbridge, and the brief I was given was delirium, but I'm actually going to talk a little bit broader about dementia care. And so please, can people just, if the slides are not moving or anything, any questions, please just shout out. It's a small group, so we can we can be reasonably sort of interactive. So I'm just going to talk about dementia care. Just going to start just by outlining some statistics, and the bulk of the talk is around delirium, but also I'm going to touch on pain in dementia, as well as behavioural and psychological symptoms in dementia, BPSD. And then the last few slides are just some of the things more relevant to the hospital, but it's good to know what's going on in the hospital. And so, you know, if your patients need to come in, you sort of understand what sort of things that are happening. So just to start with the some statistics, this is from the Dementia Statistics Hub, and everyone's heard about 1 in 2 people affected by cancer. You know, people have, you know, and then in the news and the popular media, people say 1 in 2 of us affected by cancer in our lifetime. Same is actually true for dementia. So either 1 in 2 of us will be affected by the condition itself, or you may be caring for someone with dementia. So it's you know, it's something that's going to touch everyone's life. Everyone's sort of aware of it, much more awareness these days, because it's getting common as our population ages. So it's something that's in the public consciousness. At the moment, 1 in 14 people over the age of 65 have dementia in the UK, and that works out to just under 1 million people living with a condition in this country, and that will rise to about 1.4 million by the year 2040. So it's, you know, it's not something that's going to go away. It's going to be certainly, obviously, in your day-to-day work, it's something that you come across all the time, but also in your personal lives as well. You almost certainly have dealings with it. So as I say, the main talk is about delirium. So it's obviously distinct from dementia, but so delirium can occur for people without any history of confusion or cognitive problems or dementia, but it's more commonly seen in dementia. And what are the signs? What are the signs that someone might be delirious or something's going wrong? Well, something, it's sudden onset, so it's something that's happened sort of quite quickly. There could be fine or at their baseline, and then very suddenly overnight or in a few hours, they suddenly become very confused, and they can fluctuate. So they can be very alert and orientated and or perhaps hallucinating, quite agitated, and then fluctuating, and then suddenly quite sleepy. So they're going up and down, they're fluctuating, they're quite distractible. So they get distracted by noises or something that's sort of happening elsewhere. Impairment of consciousness is another feature. So that means either they're hyper alert or they're perhaps drowsy. I'll touch on that in the next slide. And also quite disturbed cognition and disorientated as well. And the memory can be impaired. Sleep and wake is not quite as normal, and then perhaps more emotionally disturbed. So the key thing is about sudden onset and their change, especially their cognition and their thinking. So how do we spot delirium? So in the hospital, what we should be doing is for everyone over 65 who comes to the hospital, regardless of whether they're confused or not, we do this thing called a 4AT. So there's a 4AT, there's an app you can download from Apple Store or Google Play, and it's just basically 4 steps as it suggests. So the first step is about alertness. So someone's normally alert, or something's not right, they're quite drowsy, or they're hyper alert. So that's, you get a score of 0 or 4, and then you do a very quick mental test score. So you ask them their date of birth, where they are at the moment and the current year, and based on that you give them a score of 0, 1 or 2. Then you ask them to say the months of the year backwards from December, and if they get more than 7 right, that's fine. If they refuse to do it or they can't do it, they get either 1 or 2 points, and it's broken down there. And it's, again, this is backed about acute and fluctuating course. So if there's something acute, the sudden change, they get 4 points. But if they're not, if this is their baseline, there's no points. And then you can tot up the score, and the app does it for you. And basically, if it's 4 or above, then this is possibly delirium. We're doing 1 and 3, then perhaps it's just sort of cognitive impairment. But it's really, if something's not right, something doesn't seem right, it's worth just doing a 4AT score. That's the gold standard. But even your kind of instinct saying, look, this person is not themselves, is very valuable. It's a very valuable insight. The types of delirium. So there's the common sort of the one everyone thinks of when they think of delirium, which is the hyperactive, very agitated, hallucinating, behaving inappropriately. But the more common type is the hypoactive, the quiet delirium. So that means they're just a bit more sleepy than usual. They're just not eating or drinking much, they're just falling asleep. And that's actually can be missed quite easily, especially in hospital, where we don't necessarily know our patients as well as you do, or your residents. You just think, they're a bit sleepy today, and it can be, and as I say, it can be missed quite easily, or they can fluctuate. So people can be very active, very hyper agitated, and then be very sleepy a few hours later, or the next day. So these are signs of fluctuating delirium, so a mixed delirium. So which people are more likely to get delirium? So people who are older, people who have pre-existing memory problems like dementia, an infection, if someone who's got an infection, or they're dehydrated or they're malnourished, they're on lots of tablets, they're very severely ill, or they're sleep deprived, constipated. But then things that we can do, and we end up doing in hospital, like, for example, they come to a different place, we move them around from A&E to a ward to another ward, or they've come to hospital because they've broken their hip, we put a catheter in. People move around, they might lose their glasses or their hearing aids. All of these things can add to the risk of delirium. And then things like alcohol abuse, immobility are there as well. So there's various risk factors for delirium, but the main ones are sort of older age and pre-existing memory problems. So what do we think? So someone we think is delirious. So what are the causes? There's various sort of ways of thinking about it. This is quite a useful acronym, which is sort of widely used across the country, and it's Pinch Me. So it's an easy sort of thing to remember. It's an acronym. So pain, And again, I'll have a whole section on pain, but pain is so important to think about as why someone's not behaving like their usual self. Infection, obviously everyone thinks of urinary tract infection, but it could be chest or a cellulitis leg infection or some other sort of infection. They're malnourished. That can sometimes do it. And constipation, C for constipation, and I've also put in urinary retention because that the two can go together. Someone's very constipated, they can go into retention of urine, and that can cause them to become delirious. That basically means they can't pass urine. So you may notice that someone you're looking after hasn't passed urine for a day or something like that. And they're not behaving like themselves, perhaps ringing alarm bells. And things like hydration, someone's dehydrated, that could be causing the delirium. Tablets, things that we doctors prescribe, so a new tablet, that might be the cause of their delirium. And environmental triggers, as I say, someone who's just come in or moved from their home to a care home or to a hospital, that change in environment just by itself can cause delirium. And the thing about delirium, like everything in the elderly, you can have more than one thing. There can be all of these things, or some of the combination of things. So that's so important to remember. Just because you found one cause doesn't mean there isn't another cause or another 3 or 4 causes. So the PINCH-ME is the acronym for causes of delirium. So what can we do? So someone who is delirious, we'll treat the infection if there is an infection, or if their oxygen is low, that you might put them on oxygen, certainly obviously in the hospital. Try not to move them around too much. So hospital isn't always the right thing. So someone is ill, they're delirious, and you can treat them in their own environment. That's better, because by moving them you can worsen their delirium. And having appropriate lighting and orientation with clocks, calendars, so they know what day it is, whether it's morning or night, where they are, and so forth, and giving clear information to them as well. Just you're in wherever you are, and then you introduce yourself, explain what you're doing, and then keeping people busy and active, encouraging regular visitors. So having a familiar face rather than the strangers they don't recognize, that can be very reassuring for anyone, but especially someone who's already delirious. So how do we prevent delirium? So we're trying to identify those people who are at risk. We try not to change things unnecessarily. Again, this is the hospital. We try not to put in catheters unnecessarily. So someone is incontinent, that's not a reason to put a catheter in. But obviously, if someone needs a catheter, then that's of course the right thing to do. And then look at things that might be causing delirium, such as infection and pain. Pain, again, as I say, we'll talk about. Ensuring they're well hydrated and they're getting food. Look at their tablets. Obviously, that's something you'd ask the doctor to do, to look at the tablets. But it may be that you've noticed something, that they've started this tablet and they're behaving differently. So it may be just to raise the flag. Getting people up out of bed, try and get them to walk, making sure they've got their glasses, their hearing aids, don't disturb them during their sleep. So those sorts of things can prevent delirium, or certainly stop it from worsening. And this is just a brief sort of summary about the 3D. So delirium, which is the bulk of this talk. So sudden onset, and can be just and typically lasts sort of hours, but can take months to resolve, especially if it takes a long time to diagnose them. Whereas a dementia is a more kind of insidious process, people going on, becoming more forgetful for months, years. And depression, that sometimes it can you can mix up depression and dementia, and that can, if untreated, people can look like they've got dementia and they're just with their low mood. They typically in depression, if you ask people questions, they'll say, oh, I don't know, don't ask me all these questions. And it just makes you wonder, is there an element of depression, something called depressive pseudo dementia, which is like they look like they've got dementia, but actually they're depression. You treat their depression and their memory and everything else improves. And delirium, as I say, is a
okay. Do you have the office number that you've been calling on?
Oh, sorry.
There's a WhatsApp. Can I give you my email or the WhatsApp?
Do you mind? Just thank you. Okay, so delirium, as I say, is sudden onset, fluctuating course, whereas dementia is a gradual loss of loss of memory function. Hallucinations you see more typically in delirium. You can see it in some forms of dementia, especially something called dementia with Lewy bodies or Parkinson's dementia, and hallucinations you can get in severe depression. Sleep can be disturbed in delirium or depression, and not typically in dementia, but it can be normal, but sometimes you get day-night reversal. So so there is some overlap. Obviously people can have more than one condition, they can have all three, and it's trying to identify those. But those are the sort of 3Ds you're thinking about when someone isn't themselves, someone they're worried about is their memory. So the next section is about the management of pain in dementia. And this is obviously, as I said, this is a cause of delirium. So there is some overlap with delirium. But the reason I sort of mention is that we don't think about it as a cause of why someone is behaving in a challenging way or why they're not behaving like themselves. And people with dementia are 50% less likely to get painkillers than anyone else. And that was a study from about 11 years ago. So it's something we don't always think about, and that's why I've got this whole section on pain. So why don't we recognize pain in dementia? So it may be that that person isn't able to tell you that they're in pain. So they're not able to say they've got their knee hurts or they've got a headache or whatever it is. They may just sort of be crying out in pain. They may not remember that they've got a sore knee. So if you or I had a sore knee, we'd make sure we didn't move it. But if you've got dementia, you might forget and you might keep moving it and get more pain. So the cycle continues. And then the patient with dementia can't tell you where it hurts. In the past, and sometimes even now, you hear some people say, behavior because they're in pain is just because of their dementia, but people with dementia don't feel pain, or that somehow their pain is less severe. They feel pain just like you or I. So it's important that we treat them in the same way, and then as I say, we not recognize their pain. So it's important to keep an open mind as to why they're behaving like they are. When you know your residents, your patients well, you can sort of spot the signs where they're in pain. You can see this picture of this gentleman when he's relaxed and when he's in severe pain. And when you look closely, you can see that he's clearly in pain. You can see various descriptions of his muscle expression, but even just as an intuitive thing, just as a human being, you can see that the picture on the right, he's someone who's in pain. But especially important when you know that person, because you know what they're like, and also engaging with the family, because they will tell you what they're like, and and they'll tell you if they're in pain. How do you tell someone's in pain? So they might behave differently. They might become more aggressive or shouting or swearing. They may be trying to get up, walking up and down, trying to leave, not eating or drinking, behaving differently. But the key thing is at the bottom here, individual responses. So speaking to relatives and carers about what they're like normally and how you know they're in pain. So so it's just about, again, you obviously know your as in hospital, we don't know our patients as well as your residents. So we're relying on that sort of other information, but it's important so you can sometimes spot that someone's not behaving like themselves, and just thinking, is this pain? And we're all different. Just like people with dementia are all different, we're all different in pain. So some of us might, when we're in pain, sort of become very angry and aggressive. Others might just sort of go into a corner and sort of rock ourselves to comfort, or just go into a dark room, or become more withdrawn. We're all different, and so similarly, people with dementia are all different, and they will behave differently when they're in pain. So that's the point of this slide. If someone can't communicate and can't tell you about pain, there's something called the Abbey Pain Scale. There's something called Pain AD as well, which is a scale of measuring someone, assessing someone who's got dementia. So there's 6 indicators. You can see them there: vocalization, expression, body language, change, physiological and behavioral change, as well as physical changes. So and each one is rated 0 to 3. And the idea is you look at this person for like 2 minutes, 5 minutes, and then for each of those domains, you give them a score, and you can get a number out of it. And that's sometimes quite helpful, especially if someone's not able to communicate and you think something's not right. So just to use something that's validated, which is the Abbey Pain Scale. I don't know if you're using something like this, but just to make you aware that there are tools for people who can't tell you they're in pain. It doesn't always have to be 0 to 10. Give me a number, what your pain is like, 10 being the worst pain ever. If someone can't verbalize, you can use these sorts of scales. As I say, there are other scales as well available. So that's the Abbey Pain Scale. And so someone has got pain. So what do you do? Just simple, regular painkillers and analgesics. That means that if you're going to do something that's painful, like get someone to come up and walk or have a physio session, you might just want to give them some extra pain relief before they have that physio session. Trying to reassure people. Just being human with empathy and kindness it's holding someone's hand while they're in pain is so powerful. And carrying out procedures, whether it's addressing changing them or changing a dressing, trying to do it in a way that minimizes the pain. Things like air mattresses, air cushions, even heat pads, to try and lessen someone's pain, and distracting people, keeping people's minds active, give them something else to think about, can help with pain as well. So those sorts of things we can do. So the next section, I'm happy to take any questions if there are any, otherwise we can say the questions to the end. But the next section is about this thing called BPSD, and that's behavioural and psychological symptoms in dementia. And so basically, what does that mean? So we basically, some people might call it challenging behaviour. There's some controversy about whether we call it BPSD at all, but we all sort of know what we mean. But so any sort of behaviour which hurts us, scares us, angers us, frightens us, irritates us, or hurts us. So it may be things like delusions, hallucinations, agitation, aggressions, irritability, or just their cognition sort of getting worse. So that's a broad definition of BPSD, behavioural and psychological symptoms in dementia. So, as I say, what kind of behaviour? Calling out, aggression, being angry, refusing care, asking the same question again and again, that sort of thing. So those are types of behaviour I'm talking about. In the past, people thought that the dementia itself was somehow damaging the brain, and that was causing people to act in these sorts of ways. But now we're slightly more enlightened, and basically what we've tried to come to realise is that we're looking for why someone's behaving why they are, and like physical factors, social factors, environmental factors. That's behind the behaviour, that's driving the behaviour. So it's not the dementia itself, it's unmet needs. So what I'm going to do, just before I talk a little bit about sort of unmet needs, I'm going to just stop sharing this presentation. I'm just going to do a little Mentimeter, and so just try and get some interaction going. So hopefully this will work. So if I could ask you to get your phones out, and then we just do a very quick exercise on this Mentimeter. So if I could ask you to get your phones out and go to menti.com. At the top there, 75803573. So if people could do that, please. And then hopefully you'll go to this page. If there's a problem, we can abandon this. But I just okay, so one person's joined. Thank you. So basically, you'll have a screen, and it will say, "How would you feel if?" And you just imagine the scenario: you're asleep in your bed, and then suddenly, a person you've never seen before wakes you up, and they start pulling off your night clothes. So I just want you to just put up to 3 words about how you would feel. So there is a profanity filter, so so you have to please do not swear. But
sorry, can you give it out again, please?
Yes. So menti.com, MENTI.com. Can you see this screen, by the way?
Yes, I can.
Yeah. And at the top, you can see the code 7580.
Sometimes it can be quite small because if you're on your phone,
Okay,
it'll be
no
very
problem.
small.
Yeah.
So the website is literally, you don't have to put down www dot, just menti, MENTI dot,
Mhm.
and then com. And then you
Okay.
can put that code. Once you're in there, let me know and I'll tell you the code.
Yes.
Okay.
Yeah. Thank you. So that's fine. We've got 4 people joining, which is good. It's lovely. Thank you so much. So someone's great. So 7580 3573, and Osmo will repeat the code as needed. But basically, it forms a word cloud.
Okay, I'm there now. Sorry.
Lovely.
75.
Thank you. 7580
80. Yeah.
3573.
Okay. All right.
Yeah. Lovely. Okay. And so if you don't have to put 3 words in, but up to 3 words about how you feel in this particular situation. So you're alone, you're in your bed sleeping, and then suddenly someone you've never met before starts pulling off your night clothes. How would you feel? And I think some people have started engaging, which is great. So frightened, you can see is the big one. Scared, shocked, angry, confused, worried. So again, we'll just get a few more responses, and we'll just go on to the next one. So try and remember these words.
Oh.
Yep. Okay.
Am I still on? Okay.
Yeah, we can hear you. Yeah.
Okay.
Okay, that's fine. Okay, so if you imagine the situation, so someone with dementia, for them, if someone starts changing their pad or addresses their personal hygiene, for them they may be just thinking that they're in their bed and suddenly this strange person who they've never met before starts putting their clothes, so they're actually quite frightened, and all of these emotions, their emotions are the same as you or I, but that's what they're feeling. Possibly angry, absolutely angry, confused. Yeah, thank you. Okay, so we'll move on to the next one. I'm conscious of time as well. So we'll move on to the next scenario. Thank you. Yeah, brilliant. So we're on to the next slide. So this is a different scenario now. So just imagine you're in a country far away from home. You've never been there before. You don't speak the language, and then suddenly you become separated from your friends and you realize that you're completely lost. Again, if just up to 3 words, just how you would feel. Yeah. It's quite a mixture of things, I know, but all these things are quite sad. Okay, so all sad, depressed, confused, anxious, yeah, so helpless. So again, perhaps we're more guilty of it in hospital. You often use jargon and use strange words that people have never heard before, and people do. It's very lonely, as I say, being in not being in your own home. So that's perhaps how. That's how we would feel in a foreign country, and we didn't speak the language, so it may apply to some of our residents or patients. So just one more of these, and then so just imagine you're at work, and then suddenly, without any warning, you get a stomach ache, and again, without realizing what's happening, you defecate in your own clothes. How would you feel? So just up to 3 words. So embarrassed, yeah. Okay, just wait for a few more responses. Silly. Oh, yeah. Yeah, embarrassed. Yeah. Thank you. Right. So just remember some of these emotions that we all feel, and ashamed, embarrassed, upset. Yeah. Okay. Fine. Thank you for engaging and your response. I'm just going to end that little bit there, and we'll stop sharing this one, and we'll go back to the main presentation. There it is. Okay. Okay. So back to the slides. Just so types of behaviour we've talked about, and this is the how would you feel if. So as I say, in the past, people thought that dementia was causing people this agitation by itself, and somehow the dementia was causing brain damage, and people would just act in this way. And there's an advert. This is from an advert from, I think, probably from the 1950s or something, for a drug called Thorazine, which I don't think we use anymore, which is an antipsychotic, a sedative drug, very powerful sedative drug. It says for prompt control of senile agitation. A gentleman waving his walking stick, and so basically the management was just trying to calm them down, give them these drugs to quiet them down. We've moved on, as I say, we're a little bit more enlightened than we used to be. And then what we have now is the unmet needs model. So behavior is when we're not meeting people's needs. So what are unmet needs? So there may be physical needs, again, pain. I'm putting there dehydration, constipation. You'll remember the pinch me list. So that sort of thing. Are we not meeting their physical needs? But also they're not feeling safe. They may feel unsafe because someone stranger has come into their room. They just feel bored. It's just sitting there, nothing's happening, and they just feel like they ought to do something. Perhaps in their lives they've been very, they've been a very busy person. They've all had something to do, and suddenly they're just sitting there and just have nothing to do. So no occupation, nothing, no to do, and just sort of social human contact. Need to know what's going on. As well, just to straighten, as I say, to mention the not being in a foreign country, so people just speaking a strange language that you don't understand. So all those emotions of whirring through your head. So basically, it comes back to behavior is communication. If there's nothing else you remember about behavior and psychological symptoms in dementia, BPSD, just remember behavior is communication. So someone is behaving in a certain way, they are trying to communicate to you. They are trying to tell you something. And it's our job to try and figure out what that message is and try and address it as best we can. So that's the kind of take-home message for BPSD. And the reason I'm talking about this is that, as I say, in the past and even now, we do use antipsychotic drugs for people who are behaving in a challenging way. And that may be because they're a risk to themselves or risk to others. A report from approximately 15 years now by Professor Banerjee said that he estimated that 150,000 people with dementia in the UK were being inappropriately being prescribed these antipsychotic drugs, and they were causing 1,800 deaths a year. So basically, these drugs that we prescribe for challenging behaviour, things like risperidone or quetiapine or olanzapine, these are sort of major or sort of so-called antipsychotic drugs. They were actually designed for people with schizophrenia, so young people in their 20s, 30s, 40s with schizophrenia, sort of more sort of physically resilient, and we're using these drugs for our frail older patients, and so they're much more sensitive. Our patients who are frail and older are much more sensitive to the side effects from these antipsychotic drugs. And what are the side effects? So drowsiness, worsening of dementia, things like Parkinson's-like side effects with stiffness and tremor, can't doing their sort of normal day-to-day job, day-to-day tasks like going to the toilet, eating and drinking, slurring of speech, water retention, increased risks of blood clots in the leg, DVTs, and on the lung, PEs, chest infection, and then increased risk of stroke and death as well. So as I say, they estimate that if you treat 1,000 people with BPSD with an antipsychotic drug like risperidone for around 12 weeks, that will result in an additional 10 deaths and 18 stroke-like events, about half of which may be severe, and about 50 to 100 people get some sort of disturbance with their gait. That's treating 1,000 people with these drugs for just 12 weeks. And sometimes our patients are on for a lot longer. So what should we be doing? So if someone is on these, if someone is behaving a certain way and someone's thinking about prescribing, obviously I appreciate that you don't prescribe, but thinking about other causes, so pinch me, pain, infection, and so forth. Involve that person if you can, their care and their family, and say, look, we've tried everything, but we think they need to go on an antipsychotic drug like risperidone, and but it does have side effects, like drowsiness and these Parkinson's-like side effects, and saying, why am I prescribing this medication, and what am I trying to hope to achieve, and then what's my plan to try and come off this drug. So it's not just about starting the drug, it's about monitoring that person and having a plan to come off those medications, as I say. And as I say, risperidone is the only one that has an official license, although we do use other medications like olanzapine and so forth to these drugs, and these are the antipsychotic drugs. So that's why we're quite mindful about prescribing these drugs. Sometimes you do need to prescribe them, so they're not banned. No one's saying that these drugs are, completely off limits. Sometimes you do need to prescribe these drugs. Someone's a danger to themselves or to other people, they're harming themselves, or so agitated, it's they're clearly quite distressed, so you might have to prescribe something. But my point is that you're just trying to go through that process, trying to understand why they're behaving the way they are as best you can, trying to look for those reversible causes. And then if you can't, then maybe you have to prescribe something or recommend prescribing something. That's the bulk of my talk. The last few slides are just about some things we do in hospital. It's something called the butterfly scheme, which is for people who have dementia. And we call the blue wristband as well, which this butterfly was developed by, and it's a national scheme.
Oh, I'm
scheme. So
Khalid, I don't know if it's just me.
So go on. Yeah.
Khalid, you just Khalid,
yes.
you're just breaking up
Okay.
a little bit. So can you repeat the butterfly scheme bit, please?
Yeah. Sure, thank you. So the butterfly scheme is in hospital. It's an opt-in scheme, and it's developed by a carer, and it's essentially someone who has dementia. We put a symbol of a butterfly, as you can see above the bed. Sometimes if people don't have an official diagnosis of dementia, or they're delirious, they're not previously confused, we use an outline butterfly, which is just a black outline of a butterfly, so they don't get stigmatized with a diagnosis of dementia. It may not be accurate. And then we have something called the reach approach, and coupled with the butterfly scheme is the blue wristband, which we put on our patients who have dementia, so that they can be identified. And if someone has if someone is on the butterfly, has a butterfly above their bed, or they have a blue wristband, we encourage our staff to try and use the reach approach, which is trying to remind people what's led up to this moment, explain what's going to happen, arrange their bedside to make it look accessible. So it means, for example, if I'm seeing someone, I'll say, look, you're in King George Hospital, you came here because you had a fall. I'm going to examine you. I'm just going to listen to your back, or someone's going to check your blood pressure. You're going to feel it tight around your arm, or you're going to have a blood test and it's going to feel tight around your arm. You're going to feel a scratch. So explain what's going to happen in real time. Arranging the bed, that may mean just having a picture of a loved one, or a wallet, or keys, or something like that, which makes them feel orientated. Checking their hydration, nutrition, cleanliness, and then the history. That's the last bit of the reach, of the H. That's just following the instructions and things that they like, they don't like, things to avoid. So that's the reach approach, which we try and encourage for people with dementia. And these last couple of slides are just about these new drugs which are coming. The only reason I mention them is that they're often in the newspapers, and people ask them, they sort of come to hospital and they have a newspaper cutting and say, there's this new drug, why is my relative not having it, or can you ask the doctor to put them? So basically these drugs are very they're very sort of high tech, and they train your immune system to try and target Alzheimer's proteins that cause Alzheimer's in the brain. and basically trains your immune system to try and break down these proteins. The problem is that it does cause side effects, mainly bleeding and something called ARIA, which is basic bleeding inside the brain. And people need to have regular MRI scans. It's not that cost effective. It's not been approved by the NICE people, which is basically the regulators who approve or not new treatments, and the patients need to have IV infusions. There's a recent review which said it's a trivial benefit. So just to make you aware that there are these treatments, and perhaps in the future they will come online, but at the moment they're not really being sort of widely used, and their benefit is very limited. It's not that they're too expensive. It's just unfortunately their benefit is very limited, and they have quite severe side effects. So just to make you aware, that's the only reason I put that in there, is that the people often ask about these new medicines. And that is my last slide, so I'm happy to stop sharing and take any questions. Thank you.
Thank you very much. So we'll just open to the floor if there's any questions. Anybody, so do you have any case you'd like to discuss, any questions that's come out from your experience? I mean, how many people on here have residents that you likely think have this, whether chronic or acute? So someone who has it for years. Do you get them on your residents? Yeah, Alice, thank you. And yes, so Rishi has a few questions. So Rishi's asking, would you be able to have the slides, and will we share it with the rest of the people as well? Yeah, we can PDF, share a PDF. Yeah. You can always screenshot as well. And, when you play the video, if you have any particular slide, plus also these topics. So if you want the Abbey pain scale on Google, if you just Google it, there's lots of images that you can print and then laminate and put it in the office. So that really helps. And, if you use these tools when you're talking to the GP and or 111, then you get a response quite quickly. Plus also it will, I think, help reassure you as well that this is not delirium, because the reason we're talking about delirium is because it has a very high mortality rate within a week or within a few weeks of it. And I've actually seen it, and I'm sure you've seen it as well. Now, it's very different to somebody who is always like that. So like at the care home I visit, I have 2 residents there that every week I know their name is on the ward round, because they're always shouting, they're always calling out, they always want to go home, and they always want their mummy. And those ones, I have given them a little bit of diazepam when they've been distressed, like when they were crying incessantly because nothing was working. We were trying to reassure them that mummy's not here, but I'm here, talk to me. We gave them hugs. We gave them the anxiety doll. We have a purring cat as well, like a machine purring cat, because she had a cat and she was a cat lady. So she had lots of cats actually. But nothing was working that day, so I did give her a bit diazepam to just relieve her anxiety. She was so upset. But actually, that is obviously not delirium. That is that's the behavioral issue. But I don't think it's ethical to drug them with antipsychotics or give them risperidone just for that, because risperidone carries a huge metabolic load. So one, it does give them a higher risk of heart attacks and strokes. So we just have to be careful with these medications. Who are we trying to treat in this? Is this we're trying to make it easy for us looking after them, or is it something that I mean, I really don't think that even to help alleviate the pain, the suffering of other residents, that is also a very critical question. So I usually take that kind of stuff back to the psychiatrist. So in each borough you have these MDT where you have a consultant geriatrician like Khalid, or you have a psychiatrist that would attend, and it's worth actually talking to them, because yes, you've got the residents that are getting upset by it, then you've got the staff that are constantly up and down as well, and it's intense, and and now the councils and the ICB are not very readily giving you one-to-one funding as well. But I don't know, Khalid, you wanted to come in, and then there's Avril.
No, I was just going to say, I think there's a question overall. Go ahead.
Yeah, Avril, please.
Yeah, the question is, if there's a delirium, how long does it usually last? Because I have one particular client, resident, who, I mean, looking back with hindsight now, possibly was delirium, but it's lasted for her, lasted about 3 months. And she's now back to a baseline. That is, she's got dementia. She lost mobility when she came out of hospital. She was in hospital for an infection, suspected sepsis. She deteriorated quite quickly in the home, and then she was taken in, and she stayed in hospital for about 3 weeks, came out and completely lost her mobility. They weren't sure if it was cognitive because she'd forgotten how to walk. I mean, it was for a really long period though. And she's only now, after about, I would say about two months, 14 weeks, she's now back to the original baseline. So is that a delirium, a long episode?
It can be months. It can be months, as you
really.
Yeah, it can be. It's sort of unusual, but it's certainly possible. People, do talk about, and the fact that you know that person so well, it gives you a sort of a better sort of insight of things. But certainly my psychiatric colleagues would say definitely can last months, and that's why we try not to diagnose dementia too readily. We don't want to stigmatize people with the diagnosis of dementia, so someone can come in, be very confused, and it can take them weeks, maybe months to fully return to normal. But sometimes it's the dementia getting worse as well, and only time tells. So it's only when you look back 3-6 months later you think, okay, well, that was the delirium, this is dementia. But yes, certainly it can last months, typically days, short number of weeks, but typically, but it can last months. Like everything in life, there's always exceptions and things, and in medicine especially. Thank you.
No, thank you. I thought it was very helpful, the scales, like the Abbey scale, and I wasn't aware of that, and also the 4A for apps.
The 4AT. You can just go on Apple Store or whatever, free app, and it just takes you through. It's very, and it's very straightforward. That's fine. It's and it's just good because obviously it's always hard to carry it in your head, these things. So that's why there's something called Pain AD as well, but it's very Googleable. Yeah, thanks.
Okay, thank you.
Yeah, thank you. Sorry, Isma, anything?
No, I was just wondering if there was anyone else who wanted to ask. Because I was going to say that with patients with behavior, and I know you look after these residents, more of them than me, because I only visit once a week for my ward round. But you're actually living with them every day. So I'm sure you've got your own techniques. But I don't know if anybody has done that. Has anybody used classical music to calm people down? And I don't know, how do they feel? Does it work? Does it, in your experience, or do you feel like you have to do more? I know apparently the care home, well.
Yeah, no, I was going to say, so it depends. As I say, with people with dementia, everyone's different. So some people, if they like classical music, if they, if they like, they listen to it as in their younger days, that's fine. One good trick someone told me was that if you go on Spotify, look at their year of birth and add 21, and then basically go to that year and play a music playlist from that year, then that will calm them down because it will take them back to their youth. So that's sometimes work, but it's just, and just about what is that person. So it's about individual person-centered care. There's not a magic answer that you use for everyone. But I think that's about individual understanding the person. Is a thing that we have the slogan in our dementia team: remember the me in dementia. So I think that's so important. Yeah, thank you.
That's a good point. And also what I've realized is if you find out what they actually worked as, so if they were a cleaner or if they were a childminder, they were, giving them a job. So I mean, the one that at my care home, we've just given her a piece of cloth and she just goes cleaning everything. She loves it. We have a midwife as well. So we've given her a couple of babies and she's always delivering babies everywhere. And she's always busy. Every time I go up and I say, Mrs. Such and such, she goes, what do you want now? Can't you see? I'm busy delivering this baby. And we're like, oh, okay. She goes, and the resident in room 3 has had 3 babies today. Yeah. So we just keep her busy and we keep asking her, so how are your mummies doing today? And she's actually quite happy with that, you know. And before that, she was very anxious and she was like constantly thinking, I don't know what's happening at the maternity unit. I can't be off for so long. I need to really get back there. And once we kind of told her this is the unit, this is your new job, and this is all the ladies that need the babies delivering. Yeah, she's been very happy delivering babies, and I mean, the care home has invested in those anxiety dolls. They're actually quite nice. They're actually quite heavy, and they feel like a real baby. And you just hold them on your chest, and you sit there. It's like really, really nice feeling. Plus, also the purring cats, they're quite good. I don't know if any of you have anything unique, different at your care home. Do you get children visiting you from a nursery or the local school, or do you do anything different? Oh yeah, Avril, you were nodding. You have children?
Well, not, we do have children. We have a nursery that comes in like once on the Tuesday afternoon. But also one of my residents, he's got epilepsy and he has dementia, and his mother tongue is Hungarian, and for the longest time we didn't have anyone that we knew that could speak Hungarian, and we found online a Hungarian tutor who could come in and start talking to him in his language. So he speaks English too, but him connecting to somebody really in the mother tongue has really opened him up. I mean, he still repeats the same words. So it's interesting that even though he's now speaking his mother tongue like once or twice a week with this Hungarian tutor, when we've asked her what words is he saying more about his life history, she said no, he's speaking exactly the same things in English but in Hungarian. So it's really, really fascinating to see how even in their mother tongue, somebody in their mother tongue is still speaking the same words in English and in Hungarian. Anyway, so we used the Hungarian tutor because we couldn't find a care workers that spoke in Hungarian. So yeah.
No, that's a really good idea actually, to use just find a tutor, because they'll, if you can't find people who actually speak the language. Sorry, there was some noise. Yeah, and anything, anyone else have used anything unique, anything different that we could learn and for behavioral issues? We've got we had a PE teacher, and she really liked to just tell people what to do. So she did some classes, and this is somebody with dementia, so they don't remember much, but we reminded them. So every day she was asked that she's doing a lesson, and so she would just boss everyone and say, please, can you do this, follow me, and then she would do all the routine. So that way she got some exercise out of it as well. And I used to keep them busy. So, I mean, there's lots of things that people can do. Also, pets, people have animals visit the care home. We had the local aviary visit, and so they got really nice pictures out of it, with lots of owls and eagles and I don't know, all sorts of birds visiting. And the residents, they could choose which bird they wanted a picture with, and they have a picture taken. So yeah, but if you haven't got any more questions, then we could draw it to a close. There will be certificates of attendance, so you can request it. So I would say if you can email Paul or email the emails that you were getting from, I think it was from Paul or Leighton. I don't know, Paul, would you like to explain? Should they email you, or would you automatically send one out to everybody who is on here?
So long as you've registered, then I should have your email address, and I'm happy to send out a certificate. If you haven't gone through the registration process, if you've just been given the link and just attended, then maybe leave your email address in the chat so I can pick that up. But so long as you've registered, then I'll have your email address and I can send you a certificate.
Yeah, and Khalid will share his PDF with you, Paul, to share with everybody. So does anyone have any questions? Final questions? It's okay. Thank you. We've got we've got wound care next week, and we've also got another one on all sorts of tubes, not catheters though. So got PEG, trachea, and NG tube the week after that. So hopefully you'll see some of you guys there. But if not, then don't worry. You can always watch the video later on. Thank you. Take care. Bye.
Thank you. Bye.
Thanks, everyone. Take care.
Bye.
Bye.
Bye.